This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. Hope everybody had a nice Easter weekend. Today, it's really exciting that we have three of our own speakers here from Emory, and this really is a treat for us and very important because we're going to talk about the ACS guidelines, and this is the first time that we've had three of our Emory cardiology faculty on the guidelines. So just very exciting, and congratulations to all three of you. Our speakers this morning, Dr. Tanveer Rab, Dr. Goyal, and Dr. Ijeoma Isiadinso. I'm going to keep the introduction very brief. So Dr. Isiadinso is a preventive cardiologist, director of Emory Center for Heart Disease Prevention. Dr. Goyal, professor of cardiology and Rollins School of Public Health and chief quality officer for Heart and Vascular Service Line. And Dr. Tanveer Rab, professor and interventional cardiologist and section chief currently at Emory Decatur Hospital. I'm going to turn it over to Dr. Rab, and thank you so much for doing this morning for us.
Thank you very much. Thank you. Good morning to all of you for attending. It's also important to add that Faisal Merchant was a reviewer for this document, so there's actually 4 Emory faculty members involved. The order will be that Abhi will talk about diagnosis, initial assessment of ACS. I'll follow by ACS measurement of cardiac cath lab, antiplatelet, and anticoagulant therapies. And then Ijeoma will talk about ACS measurement outside of cath lab, secondary prevention, take-home messages. And just for to remind everyone that class 1 is based on clinical trials. The benefit far exceeds the risk, and the treatment is effective should be chosen over anything else. On the other extreme, class 3 is harm, again based on clinical trials, that you should not be doing or performing procedure or giving drugs that are contraindicated. In the middle, there's class 2A, where the benefits through observation and in some registries suggest that it is more useful and beneficial than the risk, whereas class 2B, there's weak evidence that sometimes the risk is greater than benefit, or benefit may equal risk. And in these cases, it may be reasonable, should be considered, or may not be considered, and that's a class 2B. And without much ado, I'll go on to Abhi, and we'll stop sharing, and so Abhi can start now.
It's a pleasure to be here with our own home audience here, and for those watching on YouTube. I'll cover the diagnosis and initial assessment of acute coronary syndrome. Section's only 6 slides, so we can hopefully get through this. We'll let the animations play out. And so when there's a non-occlusive thrombus due to plaque erosion or plaque rupture, that manifests on the ECG potentially as ST depression, as we know, or T-wave inversion. It may be electrically silent, particularly in patients with left circumflex disease. If it's biomarker positive, that's called type 1 NSTEMI. If it's biomarker negative, it's called unstable angina. We use, as perhaps just a little under half of the centers in the US, we use high sensitivity troponin assays. And so this entity of unstable angina is diminishing. I wouldn't say it's gone. It still happens, but with the very sensitive assays, markers will usually be positive if there's some myocardial injury, but we still see it, and we still need to be aware of it. If you have a completely occlusive thrombus that presents on the ECG as ST segment elevation and 2 or more contiguous leads, this will be biomarker positive if you were to draw biomarkers, but we know that if you're presenting with an occlusive thrombus where you have ischemic symptoms with ST elevation, you don't wait to draw enzymes. You need to pursue immediate reperfusion therapy, primary PCI, or reperfusion therapy via thrombolysis in rural centers. And so that would lead to a diagnosis of STEMI or type 1 NSTEMI. We did stipulate in the guideline this time, what about left bundle? And it's important to note, new left bundle should not be considered diagnostic of STEMI in isolation, meaning without symptoms. Clinical correlation is required. A new left bundle in an asymptomatic patient is not a STEMI equivalent. We took the step of actually articulating that in the document because we note that the majority of patients coming in with the left bundle probably have heart failure or some other diagnosis. And if you dig enough, you probably can find evidence of an old left bundle. So we really encourage the linkage of the left bundle on an ECG, making sure it's new and it has to be associated with symptoms. I'll transition briefly to this for the fellows. You probably have seen some version of this. This is the Emory protocol for how we classify elevated troponins. You can Google Emory troponin and click on the first link and that'll pull it up. This is also a QR code that you can scan. I'll leave that up for about 30 seconds so you can do so as I talk. It's important to note that this document really covers only the type 1 NSTEMIs and the STEMIs, which we'll show on subsequent slides here. It does not cover type 2 MIs, supply-demand mismatch, and it does not cover non-ischemic myocardial injury, which is actually not ischemic in its mechanism at all as a cause of troponin elevation. So the important take-home point from this is we should not automatically equate a troponin elevation, which is defined as above the 99th percentile. At Emory, that's above 20 in men for HS troponin, above 15 in women. We should not automatically equate that with an NSTEMI. You have to go through the steps of equating it with symptoms and then think of mechanism for that to occur. I'll let the animation play out here. The pre-hospital assessment for the management of suspected ACS. This suspected ACS is anyone who is having chest pain. The ED at Emory uses a protocol, the rapid ECG criteria, where they define suspected ACS as anyone who's 30 years or older with chest pain. And then anyone who's 50 years or older with chest pain, shortness of breath, weakness, or palpitations. It's kind of broadened out. But if you suspect ACS in the field, then our EMS colleagues will obtain a 12-lead ECG, and their target to do so is within 10 minutes of first medical contact. If they find a STEMI, their directive is to take the patient immediately to a PCI-capable hospital if one is in range, with the goal of trying to open up the artery within 90 minutes of first medical contact, which is when the paramedics or the EMTs arrive at the patient's side. If the ECG is not diagnostic for a STEMI, then you transport to a local ED and you further assess the patient in the hospital. It is important, though, that they should be obtaining serial ECGs in the field, even if the first one is not diagnostic, because it can certainly change into a STEMI, or sometimes you have a non-diagnostic ECG and they can become a STEMI shortly thereafter. And the serial ECGs is important because we know that every 30-minute delay is associated with a 7.5% relative risk of one-year death in patients with STEMI. Hence the real importance of getting them to a center where primary PCI can be done. If the patient presents initially to the hospital and does not call EMS, this unfortunately still happens in about 40% of patients who present with STEMI around the country. About 60% are calling 911. About 40% walk into an ED, which is not ideal because some of them end up not making it to the ED if they're having an active STEMI. And so that is an effort of active systems of care and local political engagement to try and reduce the barriers for people to call 911 with suspected ACS. If you suspect ACS, you get an ECG within 10 minutes when they walk into the hospital. That's a class 1 recommendation. And if STEMI is diagnosed, we'll let this play out here, then they need to immediately go for reperfusion therapy. At a PCI center, they would immediately go to the cath lab for PCI. If they're at a rural center and not in range of another PCI center, then they may get fibrinolysis, which I'll cover on the next slide here. If they don't have a STEMI, then they get serial ECG monitoring and serial cardiac troponins, and then they go into a clinical decision pathway used to define risk. as intermediate, low, and high risk. I'll actually use this part to segue into another part of the Emory protocol. This is a continuation of the slide I showed earlier on troponin classification. This is my second to last slide in this section. This is what, again, if you Google Emory troponin or you use the QR code here, it'll pull up this Emory Emergency Department protocol. This is for the main Emory hospitals along with Grady. Emory Decatur Hospital uses a different assay, and so the numbers are going to be slightly different for Emory Decatur Hospital. The important thing to note is that our protocol this is not just a troponin protocol, this is also a chest pain and an ECG protocol, like the guidelines continue to recommend. And so I won't go into this in detail, but the point is, if they come in with ischemic symptoms and they have a STEMI, you follow the local STEMI protocol. If they have high-risk features that are not a STEMI on the ECG, they're called high risk and may have a type 1N STEMI, and cardiology needs to definitely be consulted at that stage. If they have very low troponins and their ECG does not show high-risk findings, they can be discharged from the ED, considered low risk with early outpatient follow-up. And then middle of the road features, if they have troponins that are elevated but not very high and not overly concerning ECG findings, they may go to the CDU for further testing. This is my final slide here, reperfusion at non-PCI capable centers. If a STEMI is not present when the patient presents, this is at a center that cannot do 24 PCI, a 24/7 PCI, then if a STEMI is not present, then you don't want to immediately give fibrinolysis. Obviously, you need to further work them up. But if a STEMI is present, then you need to first ask, is there a contraindication to fibrinolysis, such as hypertensive emergency, recent neurosurgery, history of hemorrhagic stroke, etc. If any of those contraindications are there, then you need to transfer to a PCI capable immediately, a stat transfer for primary PCI. If there is no contraindication and you have you're within 12 hours of symptoms and there's going to be a delay in transferring to get a patient to a cath lab, then you want to administer fibrinolysis. If, however, there is a delayed presentation from symptom onset, then they can go to a PCI capable center for primary PCI, and that's a class 2A recommendation. With that, I'll transition over to Dr. Rab for his section, and I'm going to stop sharing my slides here. Thank you.
Thank you, Abhi. So I'm going to talk to you about cath lab management, antiplatelet and anticoagulant therapies. The document decided to combine both for STEMI and non-STEMI, since many of the therapies are very similar in both arms. So we focused on management of patients presenting with cardiac arrest because it's a common problem. And these are patients who have achieved return of spontaneous circulation and are now presenting to the emergency room. It's very difficult to give a class of recommendation based on poor prognostic features only, because we will not have clinical trials, and most of this are based on observation and registry. So poor prognostic features, just to remind everyone, includes unwitnessed arrest, no bystander CPR, non-shockable rhythm, CPR more than 30 minutes, time to ROS greater than 30 minutes, arterial pH less than 7.2, lactate greater than 7, age greater than 85, and end-stage renal disease on dialysis. So in terms of guideline recommendations, if the patient has achieved ROS and is awake, and is present with STEMI, it's like any other STEMI. Go to the cath lab. Primary PCI is class 1 indication. If the patient is comatose but has return of spontaneous circulation in the STEMI on the ECG, if he has fewer of these poor prognostic features, meaning may have had a brief period of rest or defibrillated very quickly but still comatose, should consider primary PCI as class 1. However, the patient is comatose, has STEMI, but has a poor prognostic features, these patients need to be assessed, and primary PCI may be reasonable if you want to take them to the cath lab, and therefore we give that a class 2B. Now, if they're comatose and have no STEMI on the ECG, immediate coronary angiography is not recommended based on 5 different smaller trials. Going on to antiplatelet therapy during hospitalization, As far as oral therapy goes, everybody should get an aspirin. It's a class 1. In patients with ACS, initial oral loading dose of aspirin followed by daily low dose aspirin is recommended to reduce death and MACE. And then you have to add a P2Y12 inhibitor. So P2Y12 inhibitor is a class 1 indication. In patients with ACS, an oral P2Y12 inhibitor should be administered in addition to aspirin to reduce MACE. And then there's a contraindication to prasugrel as a class 3. If the patient has a history of stroke or TIA, prasugrel should not be given. Now, in terms of intravenous therapy, a class 2B has been given to Canglor. So among patients with ACS undergoing PCI who have not received P2Y12 inhibitor, intravenous Canglor may be reasonable to reduce periprocedural ischemic events. And such patients may be those who are comatose, who have had a cardiac arrest, or are vomiting on the table. This drug could be used. So it's a class 2B. It may be reasonable. Now, what about intravenous glycoprotein 2B3 inhibitors? It's a class 2A. So in patients with ACS undergoing PCI with a large thrombus burden, no reflow or slow flow, adjunctive use of an intravenous, and then we added this time based on 3 small trials, intracoronary glycoprotein 2B3 inhibitor is reasonable to improve procedural success and reduce infarct size. And class 3 for harm, in patients with ACS, glycoprotein 2B3 inhibitors should not be administered routinely due to lack of ischemic benefit and increased risk of bleeding. And particularly with the advent of the potent P2Y12 inhibitors, the use of glycoprotein 2B3 is almost nil now. What about oral P2Y12 inhibitors in patients with STEMI? Potent P2Y12 inhibitors should be used. So therefore, we say in class 1, in patients STEMI managed with primary PCI, prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis. Now, in patients STEMI managed with primary PCI, clopidogrel is still recommended to reduce MACE and stent thrombosis when prasugrel or ticagrelor are not available, cannot be tolerated, or contraindicated. And then in patients STEMI managed with fibrillary therapy, clopidogrel only should be administered to concurrently reduce death and MACE, because the bleeding risk with prasugrel ticagrelor really is quite significant in patients who receive fibrillary therapy, and therefore clopidogrel is the drug given a class 1 indication. What about patient non-STEMI ACS? Once again, potent P2Y12 inhibitors in patients non-STEMI ACS undergoing PCI, prasugrel or ticagrelor is recommended to reduce MACE stent thrombosis class 1. Now, there's a group of patients non-STEMI ACS who are just managed conservatively with medical therapy only, such as some elderly patients, some or patients who have established coronary disease, who is not amenable to revascularization, but still have a non-STEMI. These patients should get ticagrelor to reduce MACE, and that's a class 1 indication. Once again, when clopidogrel can still be used to reduce MACE when prasugrel or ticagrelor are not available, or cannot be tolerated, or contraindicated. That's a class 1. Now, in some patients non-STEMI ACS planned for invasive strategy with timing angiography anticipated to be greater than 24 hours, upstream treatment with clopidogrel or ticagrelor may be considered to reduce MACE, and this is a class 2B indication. Parenteral anticoagulation. So if PCI is not immediately planned, class 1 for patient non-STEMI ACS, intravenous unfractionated heparin is useful to reduce ischemic events. Again, in class 1, patient non-STEMI ACS in whom an early invasive approach is not anticipated, either enoxaparin or fondaparinux are recommended as alternatives to unfractionated heparin. For those patients who are to undergo coronary revascularization in class 1, in patients with ACS undergoing coronary revascularization, either with CABG or PCI in the same admission, parenteral anticoagulation should be continued until revascularization is completed to reduce ischemic events. Going on to PCI that's to be performed, in patients with ACS undergoing PCI, intravenous unfractionated heparin is useful to reduce ischemic events in class 1. Class 1, again, in patients STEMI only undergoing PCI, this is based on BRIGHT 4 trial, a large trial. Bivalirudin is useful as an alternative to unfractionated heparin to reduce mortality and bleeding. And certainly, this is very important in patients who have heparin allergy or a HIT. Bivalirudin, again, is very useful for us as a class 1. For class 2B, in patients non-STEMI ACS undergoing PCI, bivalirudin is given a lower grade, as class 2B is maybe reasonable as an alternative to unfractionated heparin to reduce bleeding. And class 2B for enoxaparin, intravenous enoxaparin may be considered as an alternative to unfractionated heparin type PCI to reduce ischemic events. And these are patients who say they receive sub-Q heparin during their hospitalization. It may be reasonable to convert them to enoxaparin for the procedure. Now, class 3 harm in patients with ACS, fondaparinux should not be used to support PCI because of the risk of catheter thrombosis. What about primary PCI and STEMI? So does the patient have cardiogenic shock and hemodynamic instability? And if the answer is yes, emergency revascularization of the couplet vessel by PCI or CABG is indicated to improve survival. That's a class 1. Patient is not in shock, and presents less than 12 hours. If hospital transfer is not required, perform primary PCI with goal to first contact device activation less than 90 minutes, that's a class 1. If hospital transfer is required, perform primary PCI with goal of first contact device activation less than 120 minutes, that's a class 1. If the time of presentation is 12 to 24 hours, it may still be reasonable to perform primary PCI to improve clinical outcomes. This is a class 2A. If it's more than 24 hours and the patient has ongoing ischemic symptoms, severe heart failure, life-threatening arrhythmias, primary PCI is still reasonable to improve clinical outcomes as a class 2A. If the patient is having no symptoms and the vessel is occluded, primary PCI should not be performed due to lack of benefit, class 3. What about coronary angiography and PCI after fibrinolytic therapy? So patients receive fibrinolytic therapy. You should transfer to PCI cable center immediately after fibrinolytic therapy is completed. That's a class 1. If there's suspected failed reperfusion, which means ongoing ischemic symptoms, persistent ST segment elevation, less than 50% resolution of ST segments in the anterior leads or less than 70% in the field leads, or if they have hemodynamic electrical instability, immediate angiography rescue PCI is recommended to reduce the risk of death or recurrent MI. If the patient has reperfused, early angiography is recommended within 2 to 24 hours with the intent to perform PCI to reduce rates of death or MI. That's a class 1. Now, what about non-STEMI ACS? Rationale and timing for routine invasive or selective invasive approach. Just to remind folks that routine invasive means there's intention to revascularize during that hospitalization. Selective invasive means that you will perform non-invasive testing as risk stratification before you proceed to angiography. So, if the patient is unstable with a very high risk patient with shock or symptom signs of heart failure, including worsening mitral regurgitation, acute pulmonary edema, refractory angina, hemodynamic and electrical instability, such as sustained VT or VF, immediate invasive strategy, less than 2 hours, between less than 2 hours of the onset of these symptoms should be performed as a class 1 indication. If the patient has a high-risk non-STEMI ACS with GRACE risk score greater than 140, that's again been listed in the document as a reminder to people. Steeply rising troponin values and dynamic ST segment changes, routine invasive again recommended, with timing sooner than later, generally less than 24 hours as a class 2A. If the patient has a GRACE risk score, which is intermediate, between 109 and 140, absence of ongoing ischemic symptoms, stable downstream troponin, again, routine invasive is recommended, with timing of angiography sooner than later, generally before hospital discharge or less than 72 hours, that's a class 2A. Low risk non-STEMI ACS, GRACE score less than 109, TIMI risk score less than 2, absence of ongoing ischemic symptoms, flat troponins, no dynamic ST segment changes. Routine invasive or selective invasive recommended, and you can again proceed with coronary angiography prior to hospital discharge, or you can risk stratify them during hospitalization of recurrent symptoms and then proceed to angiography. What about cath lab considerations? Radial approach is preferred to femoral approach to reduce bleeding, vascular complication, and mortality. That's a class 1. New for these guidelines, for coronary stent implantation, left main coronary artery and complex lesions, intracoronary imaging with IVUS or optical coherence tomography is recommended for procedural guidance to reduce ischemic risk or ischemic events. And this follows the chronic coronary disease guidelines in Europe for ESC, which suggests a class 1 recommendation for the same. So imaging now is a class 1 indication throughout. Now, one other thing was a class 3 among patients STEMI undergoing primary PCI, manual aspiration thrombectomy should not be performed routinely. This is of no benefit. So, management of non-fracturated artery STEMI, we try both for STEMI and non-STEMI. We made a recommendation in this document aim for complete revascularization. So, STEMI is multivessel disease, patients cardiogenic shock, perform primary PCI to culprit vessel only. Do not perform it to non-fracturated vessel at the time of primary PCI because of the high risk of death of renal failure. That's a class 3. If the patient's hemodynamic is stable, after he can be evaluated, or he or she can be evaluated for CABG after successful PCI of the infarctorated artery, elective CABG for significantly stenosed non-infarctorated arteries involving the LAD, the proximal LAD or left main is reasonable. That's a class 2A. For those who have low complexity multivessel disease, after successful PCI of infarctorated artery, PCI of non-infarctorated arteries is recommended to reduce rates of death or MI. That's a class 1. In our document, we state that it should be staged procedure and not in the same setting. However, if patients have multivessel PCI of significantly stenosed non-fracturated arteries at the time of primary PCI, we may approach it and prefer that over a stage approach, but we gave that a class 2B indication, preferring that should stage this procedure rather than do it at the same time. What about non-STEMI ACS? Again, patients cardiogenic shock, do the cupping vessel only, do not do a non-fractured artery, that's a class 3. If you are the patient hemodynamically stable, motor revascularization, CABG, or multivessel PCI, you're based on disease complexity and patient comorbidities. You can proceed with PCI significantly stenosis, non-fractured arteries, reduce risk of death or MI, improve angina-related quality of life, that's a class 1. And only in non-STEMI did we add this portion. Physiological assessment, non-culprit stenosis may be considered to guide revascularization decisions, that's class 2B. The strength was not that great to give that a class 1 recommendation. But what about CABG? We didn't really give a guideline recommendation. We just said CABG is preferred for multivessel PCI in the following situations: includes significant left main disease, complex left main disease with severe LV dysfunction, complex with diffuse CAD, diabetes, and involvement of the LAD, pretty proximal LAD. Now, we revamped this section, ACS and cardiogenic shock. So once again, class 1 in patient with ACS, cardiogenic shock, hemodynamic instability, emergency revascularization of the cupping vessel by PCI or with CABG is indicated to improve survival, irrespective of time for symptom onset, and generally sooner the better. Class 3 harm, once again, we said PCI of non-fractured artery should not be performed. New for this section in terms of mechanical circulatory support, class 2A in selected, highly selected patients, STEMI and severe or refractory cardiogenic shock, insertion of microaxial intravascular flow pump or the impeller device is reasonable to reduce death. Again, this is a very selected group of patients. Now, in class 3, we expanded this. Then patients with AMI and cardiogenic shock, the routine use of intra-aortic balloon pump, once again, routine use of via ECMO is not recommended due to lack of survival benefit. We recognized overusage of via ECMO in this country without its survival benefit, and there are 3 trials related to ECMO which do not improve survival in the patient. Therefore, the class 3 recommendation for do not use these routinely. What about DAP strategies? Default strategy for the first 12 months, aspirin P2Y12 inhibitor, particularly potent inhibitors such as ticagrelor or prasugrel, post-PCI is preferred, this is class 1. In terms of bleeding reduction strategies, you could still use DAP with aspirin and ticagrelor for the first month, discontinue aspirin for 1 to 3 months post-PCI, and be on single monotherapy with ticagrelor, that's class 1. If patients are oral anticoagulant along with DAP, discontinue aspirin 1 to 4 weeks post-PCI, and do a single monotherapy, and that should be clopidogrel and an oral anticoagulant for the rest of the year. Another strategy for DAPT was a class 2B. If patients are on aspirin or ticagrelor or prasugrel, you could de-escalate potency of the P2Y12 inhibitor 1 month post-PCI and just stay on aspirin and a low-intensity P2Y12 inhibitor such as clopidogrel. That is a class 2B. Also for class 2B, high bleeding risk post-PCI, a patient with aspirin and P2Y12 inhibitor, you can stop either the aspirin or P2Y12 inhibitor 1 month post-PCI and stay on a single agent with aspirin or P2Y12 monotherapy. Finally, electrical complication and prevention of sudden cardiac death after ACS. Ventricular arrhythmias in patients post-MI, an ICG device is recommended in selected patients with an LVEF equal to or less than 40%, at least 40 days post-MI, and at least 90 days post-revascularization, reduced death. There's a class 1. This is an old guideline, and we just took it off from the 2017 HRS guideline, so we did not change that. In terms of ventricular arrhythmias, another class 2A indications, patient post-ACS, ICD implantation is reasonable in patients with clinically relevant ventricular arrhythmias more than 48 hours and within 40 days post-MI to improve survival. Now, we gave a 2B in patient ventricular arrhythmias early after MI, usefulness of a temporary wearable cardioverter defibrillator, also known as a life vest device, or other devices available in the market. It's uncertain that you should have used these devices, particularly in patients with an LVF equal to or less than 35% to improve survival. That's class 2B. What about bradyarrhythmias in patients presenting with an acute MI? There's sustained evidence of second-degree Morbus type 2 AV block, high-grade AV block, alternating bundle branch block, or third-degree AV block, persistent or infranodal permanent pacing is indicated. That's a class 1. So thank you for your attention. I'll stop sharing and hand it over to Ijeoma for her section.
All right, thanks. So I'm going to take over here from Tanveer and talk about some of the management outside of the cath lab and secondary prevention, and then I'll wrap up with the take-home points. So first things, we know that in patients with ACS, high-intensity statin is recommended. because randomized controlled trials have shown that there's an incremental benefit with reduction in MACE with the use of high-intensity statins compared with moderate-intensity statins. For those who have LDL cholesterol levels above 70, we know that there is benefit in further reduction in MACE when you add non-statin therapies. And so that is based on data from the IMPROVE-IT, FOURIER, ODYSSEY Outcomes, and CLEAR Outcomes trial, where they enrolled patients who had LDL cholesterol greater than 70. Now, how about people who have LDL cholesterol less than 70? Well, we know that the addition of non-statin treatment is reasonable and has been shown to further reduce MACE events with a relative risk ratio of about 6%. And again, that's based on data from IMPROVE-IT, where they added ezetimibe to simvastatin, and as well as from data from FOURIER and ODYSSEY Outcomes, where patients who had LDL cholesterol less than 50 had better outcomes without the negative effect of higher rates of hemorrhagic stroke, muscle events, or neurocognitive events. What about beta blockers? We know that all patients who have an ACS event who are hospitalized should be started on a beta blocker. Now, there may be some reasons early on during a hospitalization where it may be contraindicated, but really we included this here because we wanted to ensure that you revisit this issue prior to the patient being discharged from the hospital, that you do consider getting them on a beta blocker if at least some of these initial clinical issues that prevented your adding the medication are resolved. ACEs and ARBs are also addressed in this guideline. Patients who are high risk, defined as those who have an EF less than 40%, hypertension, diabetes, or presenting with a STEMI with an anterior infarct, that an ACE or an ARB is recommended. An MRA is recommended for those who have an EF less than 40%, but have diabetes or are presenting with heart failure symptoms, because that has been shown to have clinical benefit in reducing mortality and overall cardiovascular events. What about anemia? When they looked at studies of patients who had acute coronary syndrome, they found that actually following a more liberal strategy of transfusing to a hemoglobin of 10 actually reduced cardiovascular events compared to what we typically see in those who are chronically ill or undergoing surgery, where we transfuse to a hemoglobin of 8. So this is a little bit different than what we typically do in our clinical practice. And so I wanted to highlight that here, that we're really recommending transfusing to a hemoglobin of 10, and that's regardless of whether the patient has acute or chronic anemia. It is important that we are evaluating ejection fraction for patients prior to discharge. And sometimes there are some challenges with getting this done in the hospital, but it really is important because we are trying to risk stratify those individuals who may benefit from sooner evaluation within 3 months if their EF is low. And then identifying those individuals who have developed complications from ACS, whether that's papillary muscle rupture, VSD. Now, these individuals will have clinical symptoms, but we definitely want to define that. And then more importantly, you want to identify those patients who may have an LV thrombus as a result of their acute coronary infarct, because this is really going to alter your medical therapy. And this is important to know prior to discharge. Now, what modality we use to assess the EF is really left up to the clinician. And that was really because each hospital system may have barriers to getting particular tests. So you can do that using a cardiac MRI or an echocardiogram, but as long as you do this prior to discharge. I'll let this move forward here. So here we all know that cardiac rehabilitation is important for patients post-ACS. It has been shown to improve functional status, reduce morbidity and mortality. I just want to remind the trainees on the call that importantly, it is more than just exercise training. And we really need to be reinforcing this when we're talking to patients, that this is more than just you presenting to have an individualized supervised exercise program. Here, we're also talking about nutrition education. We're talking about risk factor modification. It's an opportunity to review medications as well to ensure adherence and identify any challenges that patients may be having. And it really does provide some psychosocial support for the patients who have all experienced a very life-changing event. Now, while cardiac rehab is recommended, not everybody will have access to cardiac rehab, either due to geographics or financially, they may not be able to afford the copay for cardiac rehab. And so home-based cardiac rehab gets a Class 2A recommendation. And that's really just to ensure that everybody gets access to cardiac rehab. It is important that we address clinical inertia. We know that patients are started on statins. That is easy for us to do, start them on high-intensity statins in a hospital. But then what happens after they leave? We do see that there's a high rate of statin discontinuation, whether due to perceived side effects or patients' misunderstanding of the medication. And so this is just a reminder that we, should be checking lipid levels 4 to 8 weeks after either initiation of therapy or addition of other lipid-lowering therapies. And then if the LDL cholesterol is high, this is our opportunity to intensify therapy. But if it is low, please do not discontinue the statin. And I have seen this many a times, and I'm sure some of you have as well, when I see my patients in clinic post-acute coronary infarct. Colchicine it gets a class 2B recommendation in our guidelines. From the cold-cut trial, we saw that patients who were randomized to colchicine plus guideline-directed medical therapy versus usual care alone, that those who received low-dose colchicine had a reduction in MACE events. And so it is recommended that it is reasonable to consider the addition of colchicine after ACS. We do know that patients who have influenza are at increased risk for cardiovascular events and morbidity as well. Specifically, influenza infection may contribute to atherogenesis and plaque destabilization, thereby precipitating an ACS event. And so influenza vaccine has been shown to reduce the risk of death and MACE. And so that is why it gets a class 1 recommendation in our guidelines. While we know that COVID infection and pneumonia also increase risk of cardiovascular events and deaths in patients with ASCVD, there wasn't really enough randomized control data for patients specifically who had ACS for this to be included in the guideline. Now, we do recommend that you follow national guidelines and CDC recommendations about the use of pneumonia and COVID-19 vaccinations for all patients, but specifically for ACS, we recommend influenza vaccination within at least a year from the event. And really, we should try to do that during the hospitalization. What about post-discharge follow-up and really coordinating care in the outpatient setting? We've talked a little bit about clinical assessment and referral to cardiac rehab. Really, what I want to drive home here is addressing social determinants of health. This is really our opportunity in the clinic to identify those barriers to medication adherence, to compliance or follow-up with cardiac rehab, identifying for patients if copay is an issue, so you can connect them with some resources so that they can get medications covered, even if it's partially. And then obviously engaging family members or whoever the patient identifies as a trusted caregiver, so that we make sure that the entire network that is caring for this patient has a good understanding of their cardiovascular disease and how to manage their care. So I'll summarize by including some of these take-home messages from all of our sections here. First and foremost, dual antiplatelet therapy is recommended. Ticagrelor and prasugrel are preferred over clopidogrel for patients who have ACS undergoing PCI. 12-month therapy is what we're recommending for patients who has ACS. So aspirin and whatever your choice of the P2Y12 is continuously for 12 months, unless they have a high risk for bleeding. If they do have high risk for bleeding, there are a number of strategies that we've included here in the guidelines that will help to reduce that risk, whether you use a proton pump inhibitor, transitioning to monotherapy with ticagrelor after 1 month. And for those who are on oral anticoagulation, discontinuing aspirin after 1 to 4 weeks and continuing with just a P2Y12. I've covered statin therapy. Again, remember that if their LDL is above 70, please add non-statin lipid-lowering therapies. More importantly, it's reasonable to drive the LDL cholesterol even further because there is added benefit. If you are going to pursue an invasive approach, certainly for those who have non-STEMI who are at intermediate to higher risk of ischemic events, this is recommended. And for those who are at low risk, further testing may be necessary to determine whether or not they would benefit from revascularization at that time. A radial approach is preferred over femoral approach, and intravascular imaging is recommended to guide PCI, especially in those who have complex lesions. Complete revascularization, as you heard from Tanveer, is recommended. Whether you use CABG or PCI really depends on the complexity of the disease and the comorbid conditions for your patient. Certainly for STEMI, PCI of other significant non-culprit lesions can take place, whether at the same time or staged. But those patients who have ACS and cardiogenic shock, we really should be focusing on revascularization only of the infarct-related artery and deferring the non-infarct-related arteries to another time. Microaxial flow pump is can be beneficial for those patients who are presenting with MI and cardiogenic shock, but we do need to take into consideration some of the risk that come along with that. So careful selection of patients is important. As I mentioned, transfusion for your ACS patient who has anemia has been shown to reduce cardiovascular events, and which should be transfusion to a goal of 10. Remember to check the lipid panel 4 to 8 weeks after initiation of statin or after addition of any other lipid-lowering therapies. Let's address the clinical inertia that we're seeing so we can get our patients to go and prevent recurrent events. And if your patient was referred to cardiac rehab in the hospital, has not gone where you see them, please reinforce that in the outpatient setting. So with that, I'll stop sharing and turn it back over to Pooja.
All right, great. Thank you so much for reviewing and summarizing all the key points that we needed to know about ACS and an update. And congratulations to all three of you again and our reviewer for being involved in this. I know it was a lot of work to be part of Guideline Writing Committee. So thank you so much and congratulations. I'm going to open it up for questions. I'm sure we have lots of questions. And while we're waiting, I'll go ahead and ask, maybe this is for either Dr. Rab or Dr. Isiadinso, but whenever we discharge patients on DAPT, are you going ahead and adding a PPI, for people, because most of our patients, I feel like they're at risk of bleed. But I wanted to hear your thoughts about that and which PPI do you typically reach for?
Generally, no, I do not. Generally, I do not, unless they have symptoms in the hospital. And there is some slight baggage with using omeprazole, but that's not really true. So either you can use omeprazole or pantoprazole, and a lot of people prefer pantoprazole, but I routinely don't do that.
Okay, thank you.
Hi, this is Khusro. I have a question for Ijeoma. Has the college addressed a dental hygiene for secondary prevention? Or is there any studies where patients were sent to every 6-month dental care, and if they did better as compared to people who had poor dental hygiene?
Yeah, no, that's not addressed in this particular guideline. We know that obviously poor hygiene also is related to poor cardiovascular health. So overall, we should be recommending just as preventative strategies, good oral hygiene for our patients. But in the setting of acute coronary syndrome, no, that's not addressed in this guideline.
Does Dr. Spencer King have a question or a comment?
Hold on. Yeah, I was just trying to see in the dark so I could type it in. Was there any place for CTA in the whole process of the guideline?
No, we didn't look into that because these are acute coronary events that patients come in.
It used to be a push for CTA in the ER way back, and I just wondered, with CTA was there any? Is it nowhere? In other words, if you're going to look at the coronaries, it's all invasive in every category.
So Dr. King, that falls under the rubric of the 2021 chest pain guidelines, which include CTA as an option for working up patients with chest pain who are not having who do not end up with a diagnosis of an acute coronary syndrome. So yes, CTA is certainly in the armamentarium. That falls under the rubric of the 2021 chest pain guidelines.
Since you said that unstable angina is disappearing, but that's curious to me, because I thought in the diagnostic codes, the unstable angina seemed to have taken over, and stable angina seemed to have disappeared. So this is an acute guideline. I get it, but the use of the coding of unstable angina seems to be there.
No, it is. Yeah, I don't think I said it's becoming a less frequent diagnosis in the setting of high sensitivity troponin assays. It's still a legitimate diagnosis. I mean, we still see patients who come in with chest pain, some dynamic ST changes, and you treat them with unstable angina. That is a recognized entity and is covered in this guideline.
So in this guideline, the gatekeeper is the troponin. I mean, it seemed like some of them that were covered in the guideline, there are categories where your troponin is not elevated. So they don't qualify.
This guideline does include non-STE acute coronary syndrome, both NSTEMI and unstable angina. Those are both included. We did have a challenge for a number of the recommendations where we tried to stay true to a lot of the trials and a lot of the evidence, and many of them really only looked at NSTEMI or STEMI and just simply didn't include unstable angina. And so at every recommendation, we had to decide whether to extrapolate them to unstable angina. And that's sort of taken on section by section. But unstable angina is a recognized entity and is included in this guideline.
Gotcha.
Stan Sherman. Can y'all comment on the patient who has atrial fib and chronic anticoagulation to begin with? Is ticagrelor and prasugrel the best drug still or not?
I think that the preference is not to have potent P2Y12 inhibitors because of increased bleeding risk. And as I showed you in the DAP diagram, it's preferable to after 1 month, if you go on triple therapy with aspirin or anticoagulant and a P2Y12 inhibitor, if you stop the aspirin, the preference is to be on clopidogrel, not on more potent inhibitors.
Thank you.
A question. So if somebody comes in and let's say they're being discharged on Brilinta, and what if I know that for the first 30 days we can try to get them if they don't have insurance or if they have reasons, but then what happens after that? Because if DAPT is recommended for 12 months and just you're seeing them as an outpatient, how do you convert what from like Brilinta to Plavix, or I wanted to hear your thoughts about that.
So I think that it's not an uncommon problem, but prasugrel now is available generic, okay? So I think that's less of an issue. And ticagrelor may in the new future go generic as well. But if we have to convert out to clopidogrel, then we just would suggest taking an oral loading dose of 300 mg clopidogrel and go on 75 mg clopidogrel after that as part of the DAP therapy. But we tried to get an important inhibitor at least for 1 month and give a prescription somehow or the other through coupons, the other to get at least the potent drugs for the first 30 days.
There's a question from Dr. Walker. Is there guidance on P2Y12 inhibition testing for patients on Plavix?
So we talked about it, but we do not recommend any form of genetic testing or any kind of currently available testing in this document. Genetic testing is probably more superior in the current testing format that we have, but it's difficult to do and tedious and not commonly available. So no, in terms of, we've just felt that people who are patient of potent P2Y12 inhibitors, the genetic testing would probably not be of value. This is really more of value of patient on clopidogrel only. And if the aim is to try to get them to important drugs for the first month, where most of the thrombotic events occur, probably as you convert to clopidogrel, yes, you may have that question whether it's effective or not, but no, we do not specifically recommend any form of testing for P2Y12, particularly clopidogrel, testing efficacy of clopidogrel.
Dr. Baer has a question. Do you recommend loading dose of Plavix in ED for non-STEMI?
So nowadays, we don't do that. We suggest that that when patients come to the cath lab, the timing of effect of these drugs is 4 to 6 hours after therapy. Most of the time, to address STEMI, you usually get through the STEMI. So the drugs are not quite important. We really rely on the anticoagulation that's given them to tide them over the time period. Now, in terms of non-STEMI, we do not make any specific recommendations to load that. If you look at the diagram that we put in patients where it might be delayed more than 24 hours to perform a diagnostic angiography, we may consider clopidogrel ticagrelor at that time. That's a class 2B recommendation, but not loading the ER. I think Tala had a question also. Let's see what Tala has.
Many beta blocker trials were before the modern era. Are there recent trials or was there discussion regarding benefits in ACS without low EF?
Yeah, when I don't remember the exact date of the references that we use, but the bigger issues that we use that most of the older trials also included the use of IV beta blocker in patients who had acute coronary syndrome. And we really recommended that that had a negative benefits in individuals who had congestive heart failure, and really focusing on oral beta blockers for individuals in the acute coronary syndrome. And importantly, titrating those as hemodynamics allow. And so that's where the weight of our evidence is focusing on oral beta blockers and avoiding the use of IV beta blockers because of the negative outcomes and side effects that occurred in patients when they did enroll them in the clinical trials for patients who had ACS randomized to beta blocker use. I'm just looking at the second part of her discussion. Obviously, for those who had, those did include individuals who did not have low ejection fraction, yes. The other thing I just wanted to add, Pooja, just as we maybe wait for additional questions, is that, there are ongoing trials of oral PCSK9 inhibitors. And I think that's going to be beneficial because some of the challenges that we face are that in the hospital setting, the only thing we're able to do besides escalating the dose of your statin, if the patient comes on a moderate intensity statin, we put them on a high intensity or we add ezetimibe. That's really everything else because everything else requires prior authorization. And so that's deferred to the outpatient setting. So maybe, if we do get some oral PCSK9 inhibitors that are available on the market, those are things that we could start in the hospital. Because many of these trials have shown that if you actually add a PCSK9 inhibitor, even very early after the ACS event, and some of these trials include people who they were started on PCSK9 inhibitor in the hospital, that there was a significant reduction in MACE events. And that actually improves adherence because we know that whatever the patient is on in the hospital, they're more than likely to be taking that when you see them about a year later. And so that's on the horizon, hopefully.
And you don't think that, oh, sorry. I was just going to say, you don't think that oral would require prior auth?
I think eventually, initially it obviously will, but down the line, I think it will be beneficial when we can start adding these medications in the hospital setting.
Could you address the issue of Lp(a) because you got a lot of ACC?
Yeah, certainly those of us in the prevention world are flooding and hitting you over the head with checking lipoprotein A in patients. We know that the prevalence of elevated lipoprotein A is about 20% in the general population. But two things. Number one, we should not be checking that in the setting of an acute coronary syndrome or acute coronary presentation for our patients because lipoprotein A levels can be not accurate in the setting of acute inflammation. So that's number one. We did not include that in our guidelines because we just don't have any randomized control trial about lipoprotein A levels and lowering them in the setting of ACS. More importantly, there are ongoing studies right now that are looking at a variety of medications that have been shown to lower lipoprotein A anywhere from 80 to 90%, but the outcomes trials data are not there. So hopefully that will be on the horizon, pun intended. But for right now, we do recommend, when I say we, in the preventive cardiology world, we do recommend checking lipoprotein A in everyone at least once, but it is not included in this guideline due to the lack of data, specifically with outcomes trials and ACS patients.
Peter had a comment about the clear synergy trial. Peter, there's a hard stop to trials after the ACC because we already had prepared the document and waiting for important trials to come out of ACC 24, and we stopped after that because the document had to be ready for further review and publication. But the way the guidelines will be, as important trials come along, and there's a reason to change, segments will be changed on a modular level because we've made this into modular sections, and then we change, and the changes will be brought out and brought out to the general membership and the public online from ACC as we change it. And Peter had another question for you, Ijeoma. Should we lower LDL below 55 just after MI, or everyone has chronic cardiovascular disease?
Yeah, we tend in America to lag behind those who are in Europe, where they set a target LDL level of below 55. And we know that the lower the LDL level, the lower the risk of cardiovascular events. And so in my practice, I target lowering the LDL cholesterol level below 55, including in those who have not had an ACS event. And we really should be doing that. We have enough lipid-lowering therapies available at this time that we should be able to achieve target levels for those. Outside of those who have FH, where it may be a little bit more challenging, you need multiple therapies.
Okay, great. If there's no other questions or comments, we're right on time. So thank you so much for staying on time. This is amazing that we had 3 speakers and you guys stayed on time and we had plenty of time for discussion. So I really appreciate that. And thank you everyone for joining. Don't forget to get your CME and I will see you next week.
Thank you.
Have a good week. All right.
Thanks
Thank
for
you.
having us.
Thank you.
The preceding program is copyrighted by Emory University.